Good morning, everyone. We will go ahead and get started. Thank you to everyone for joining us on this webinar today. My name is Ami Patel, and I am one of the Pediatric Infectious Diseases faculty members here at Lurie Children's Hospital in Chicago, and the Associate Medical Director of our Infection Prevention and Control Program. As part of the webinar with me, I have Matt McHugh. He is one of the infection preventionists here at Lurie. And over the years, he has become the institution's expert on surveillance and reporting of AFM. So he has been pretty instrumental in streamlining some of the processes and protocols that we have here at Lurie for identification of cases and reporting. This webinar is an educational opportunity to raise familiarity with reporting procedures for AFM, specifically for local health departments. A similar type of education has also been created for the clinicians or infection control practitioners reporting to the local health departments. This is part of an initiative from the Illinois Acute Flaccid Myelitis Learning Collaborative, which is supported by funding from the Chicago Department of Public Health, with the overall goal to raise awareness and education of AFM. This initiative is led by Sue Hong, one of our critical care and neurocritical care intensivists here at Lurie, and we thank her and the members of the Illinois Public Health Institute for helping us put together this webinar. Heather Reed from the Illinois Department of Public Health is also on the webinar panel to help answer questions. So with that, next slide, please. So this is our housekeeping slide, just to let you know that there is a chat box where you can ask your questions and pose your questions. The members of the Illinois Public Health Institute are joining us and can monitor the chat box for any questions or concerns. And the session is also being recorded to view at a later point as well. Next slide, please. So this is an outline of what we will be discussing today. I will give a brief introduction into AFM, and then Matt will walk us through the steps of reporting AFM from the local health department lens, including the various forms and that are required in specimen collection. Next slide. So acute flaccid myelitis, or AFM, is a rapidly progressive flaccid weakness. Typically involves at least one extremity, but can also involve the cranial nerves. And the way we differentiate from other causes of weakness is specific MRI findings, which predominantly involve the gray matter, which you'll see in the next few slides why imaging findings are particularly important for this case definition. Typically, it's seen in children that are healthy and school-aged with a prodromal syndrome of fever and upper respiratory illness before the onset of weakness. And then that weakness can progress rapidly and lead to respiratory failure. It can take some time for recovery, and depending on the child, there is a spectrum of what the illness and the recovery will look like. And what we know so far is that there's no curative treatment for this disease. Next slide. So you'll see the epidemiology of AFM depicted in this slide. So the CDC began tracking this emerging disease back in 2014. And since then, we've seen sort of biennial outbreaks that have been observed with peak activity in the late summer and the fall. So if this pattern continues, this year, 2020, is predicted to have an increased number of cases. And from recent data that you can see here, so far in Illinois, there have been 3 patients that have been under investigation, 2 have which been confirmed, and 1 has been probable. However, the effects of social distancing and COVID-19 on AFM are not known, and it will be interesting to see how that may affect the epidemiology of AFM this year. Thank you. So trying to understand a little bit more about what causes AFM has been an active area of research. Enterovirus D65, EVD65, has been kind of a leading etiology candidate for many reasons as a cause of AFM. Historically, we've seen increased circulation of this virus in 2014 and 2016, both temporally and geographically, as it coincides with increases in cases of AFM. AFM has also been associated a little less frequently with other viruses, as is listed here on this slide. And what we know about trying to understand a little bit more about the cause of AFM, trying to obtain earlier sampling of these patients when they first present with clinical symptoms has yielded better sensitivity for pathogen detection. And Matt will talk a little bit more about that when he talks about specimen collection. Overall, AFM is a reportable disease being tracked by the CDC. It's important to report AFM cases to your health department since AFM is a relatively new condition. Information is needed on all patients to help us better understand the spectrum of AFM illness and causes and risk factors and outcomes, which is part of the reason we are raising this awareness of reporting processes. So with that, I'm going to turn it over to Matt now to discuss the specific steps that are required for reporting.
Hi, everyone. My name is Matt McHugh. I'm an infection preventionist at Lurie Children's Hospital in Chicago. Like Dr. Patel said, as the incidence and prevalence become more well-known about this disease, we're learning a lot more about the importance of reporting it to the state, and it's getting a little bit easier. 2 years ago, when I first started taking this challenge on, it was a little bit harder. A lot of the communication was going through email. I definitely have to shout out to Dr. Frischone from IDPH to help institute that and help us through reporting that. But I wanted to take you through today the LHD reporting responsibilities for hospitals or infection control or providers reporting AFM. So AFM can be reported to the local health department through either direct clinician report or by an institution's infection control department. We're pretty blessed to have kind of a big infection control department and have really good communication with our neurologic doctors that we're able to be kind of the hub of reporting to the state and have good direct communication with them. The LHD should ideally work as a proxy between the reporter and Illinois Department of Public Health. All this data stream should flow from the hospital or provider infection control directly to IDPH, who will then report it to the CDC. Your first step should be to verify with the clinician or infection control that the patient meets criteria for reporting, and I'll show you in the next few slides what that criteria pertains to. And then if the patient meets one of the following criteria, we want to instruct the clinician or infection control to order and collect necessary patient samples for transport to IDPH and then to CDC. Next slide, please. So as we refine this process, the AFM case criterion classification has broadened a little bit. There are 3 different case classifications. So I'm going to take you through if a physician or infection control suspects one of these, you would want to report these cases. So confirmed cases would be acute onset of flaccid limb weakness and an MRI showing a spinal cord lesion largely restricted to gray matter and spanning 1 or more spinal segments. So you can see up in that graphic up at the top, you see the constriction of the spinal cord. Next slide. Probable cases would be acute onset of flaccid limb weakness. So the patient coming in with typical either upper or lower extremity weakness or flaccidity, and MRI showing spinal cord lesion where gray matter involvement is present, but predominance cannot be determined, excluding lesions caused by physician-diagnosed malignancy, vascular disease, or anatomic abilities. The important thing to know about this classification and the next classification is even though we have indeterminate MRI imaging, we want to make sure that we don't delay the collection of specimens and reporting to the health department, as the identification of the virus is critical to the classification of AFM. So specimens should be collected as close as possible to onset of limb weakness as soon as we suspect AFM. Next slide. And then suspect cases would be acute onset of flaccid limb weakness, and available information is insufficient to classify cases probable or confirmed. So this means even less than indeterminate imaging. There's not enough information to state whether this could be acute onset of flaccid limb weakness due to AFM criteria. But we still suspect that physician would suspect that this could be a case of AFM. So we'd still want to maintain that contact with either infection control or the clinician reporter And again, if unsure about MRI findings, please don't delay the collection of specimens reporting to the health department. They should be collected as close as possible to the onset of limb weakness in order to identify that viral pathogen. All right, so who are you going to call? So once you establish a diagnosis with the clinician or infection control, notify IDPH of your intent to report a case. You want to work with the provider infection control to complete the patient summary form and to obtain MRI notes, MRI images, and neurology consult notes. I have a few links referenced at the back of the presentation on things like REDCap that you can submit through and a cloud-based photo imagery, so that if you're unable to obtain the MRI images and send them directly, that you'd be able to use one of these links. Once reported, IDPH will assign an authorization number for specimen submission. The authorization number should look like something like what's listed there below. Obviously, this would be a CDPH case, it's notated there, but all of them are going to follow a similar pattern to this, and then you would get a F3 number based on the case count, and there will be different letters used depending on that. So what's required from the reporter? So patient specimens, the following forms should be completed and included. There's the CDC specimen submission form. I have a picture and a slide about this later. CDC AFM patient summary form. This is going to be made in duplicate. The first copy is going to be included with the patient specimens. And then IDPH communicable diseases laboratory test requisition form. This is the standard form that laboratories use to send reportable pathogens like, say like an 0157 to the state for testing. And then the patient medical records, the following form should be completed with the patient's medical history. So again, that's CDC AFM patient summary form. The second copy of the form is going to be sent to LHD. The way that we typically communicate with the LHD from wherever the patient's residence is typically by fax. We take printouts and send them through. That just seems to be the easiest way with cover sheet to send the information in bulk. And then INED's electronic case report form. So hopefully everyone in the room has, or everyone on the presentation has INED's access. If you don't have INED's access, there's a link right there that will allow you to sign up. This is the main IDPH reporting system with case reports for all the reportable diseases in Illinois. So if a clinician or infection control does not have access to INEDs, the LHD will be responsible for completing this form. If the LHD does not have access to INEDs, again, you should promptly request it using that link. And then in the interim, if no one has INEDs access, the provider may report pertinent information by phone to be sent to IDPH. Patient specimens. So below are the specimens that are going to need to be collected at the onset of limb weakness or as close to it. The clinician or infection control require an authorization code from the LHD. Once this code is provided, they should proceed with ordering and collecting the following specimen types. So there's CSF, serum, stool, and then an MP or OP swab. This has all the storage and shipping requirements. One thing that we've noticed as a provider has been that when these patients come in, the typical pathogenicity comes through on the respiratory NP swab. So a good idea, if you have an RVP assay or platform or another viral pathogen platform that you can use to test for pathogens and respiratory secretions, what our lab does is it aliquots out 2 specimens for both our in-house testing and then IDPH testing, and then sends that out. So again, these specimens should be collected as close to onset of limb weakness as possible. The CDC specimen submission form, this is actually new this year, or last year. So the CDC specimen submission form, this is just a picture of it. This will be completed between the provider and the local health department. And if you go to the next slide, there's a little bit of instruction. So you want to instruct the reporter to complete a specimen submission form for each sample collected and include it with the respective sample during transport. This means that every specimen that you do have that's being stored and shipped should have a specimen submission form to go with it. IDPH laboratory will assist with the completion of the CDC specimen submission form. There's the link for it right there. So on this form, we want to select human in the specimen origin drop-down box, select enterovirus detection and identification for the test order name, and then enter CDC 10312 for test order code. Next slide. And then along with those specimen submission forms, you want to fill out the IDPH laboratory test requisition form. This again is needed for every sample that you are shipping. And again, this would be the normal laboratory form that you would send for any reportable pathogen that would be sent to IDPH. And there's a little bit of instruction in the next slide. So again, you want to instruct the reporter to complete a form for each sample collected. You want to complete the IDPH communicable disease laboratory test requisition form. It's found right there at that link. Our laboratory has copies that they maintain in the actual lab. The reason for that, each lab has a specific IDPH location that they need to fill out. And it's good practice to have that just listed on the form ready to go when you're ready to send specimens in. Each form should have a case authorization number recorded. There's only one authorization number per patient, so that one singular number should go on every form for IDPH communicable disease laboratory test requisition form. And then the transport of specimen should be coordinated with the LHD to be sent to IDPH laboratory. Next slide. So shipping patient specimens, once they've been collected and the authorization number has been obtained, you want to instruct the reporter to ship specimens along with the following 3 completed forms. So again, as said on the previous forms, you're going to use that CDC specimen submission form for each sample, the CDC AFM patient summary form, and that's just going to be one form, and then the IDPH communicable diseases laboratory test requisition form, and again, one per sample. Samples should be submitted to the IDPH laboratory at Taylor Street. The IDPH lab is open weekdays from 8 to 4, not normally open on the weekends, but hours have varied due to COVID response. So it's a good idea to call and to make sure that they are open and get the numbers, the times when they will be testing these specimens. And that's the IDPH lab contact number right there. Next slide. Patient medical records. So this is what I was referencing before, the INED's electronic case report form. Our Department of Infection Control typically fill these out for any reportable disease that we are reporting. If the infection control or the provider doesn't have access to this, you as local health department officials will have to help them through that and potentially fill it out through the local health department. So when it's reported by infection control, you want to instruct the infection preventionists to complete the case report form through INEDS. It's reported by clinician. Clinician does not have access to INEDS. The LHD will be responsible for completing this form. And then if no access to INEDS is obtained, you may report information to the LHD to be forwarded to IDPH, typically through phone. But again, please use that link provided previously to obtain INEDS access as promptly as possible. And then this is the CDC patient summary form. So this is where a bulk of the information is going. It's going to be a bit redundant to the INEDS case report form. This is going to be going to the CDC, so you may have to work with the infection control department if you're filling it out, or the provider if you're filling it out, to go through that medical record to find all the information on here. Next slide. So the reporter will be responsible for completing the CDC patient summary form located on the CDC AFM website. Here's the link. They will need to complete 2 copies of this document. Each, like I said, one is going to go with the samples to IDPH laboratory, and one is going to get faxed through the LHD to IDPH. And then in addition to the CDC patient summary form, request from the reporter MRI imaging notes, MRI images, neurology consultation notes. MRI images can either be sent to the LHD or IDPH or uploaded through the following CDC cloud-based imaging platform. This is again new this year. Typically, we would go through our medical records department, and the LHD would put a request through email to that medical records department. But now that the CDC has this cloud-based imaging platform, you can upload them directly. The second copy of the form should be included with the specimens being transported for testing. And follow-up. So once all of that information is collected and sent through the appropriate channels to the LHD and IDPH, and then onward to CDC, there should be 3 incremental follow-ups for data submission to IDPH. So that's the 60-day follow-up, the 6-month and 12-month follow-up. The questions for this follow-up are located on the back of the patient summary form and should be answered at each interval before sending to IDPH for submission to the CDC. Along with this 60-day patient follow-up, IDPH and the CDC are going to request admission notes, patient H&P, additional neurology and infectious disease consultation notes, additional MRI reports and images, diagnostic laboratory reports, vaccine registry record. Typically, as infection control, we have access to iCare, so we can see where all of those vaccinations are documented. If you don't have access to iCare, it comes through the same link as iNEDS, so that may be something to invest in. The EMG report, if done, and then a discharge summary. What we were typically doing with patients from Chicago 2 years ago was sending the bulk of this information to CDPH and then letting them, at their discretion, send it to IDPH for reference. But as far as it goes, not until 60-day follow-up would you actually need all of this information. And then the questions on the back of the patient summary form answered by the family or patient. And then again, instructions for follow-up are found on the reverse side of the CDC patient summary form. Next slide. So this is what it looks like. These are all the questions that should be prompted at the 60 and 90-day follow-up, and you can see that the box at the top lists all the necessary documentation that needs to supplement this follow-up as well. And then the process for AFM case review and classification. CDC experts will review patient case and make a classification of confirmed, probable, suspect, or not a case. Classification will be communicated back to the health department, so typically through IDPH and then LHD and then back to the provider. The health department should inform the provider of the case classification, and ultimately the provider should notify the family. So you can see it's just a flow diagram of either the CDC going to LHD or IDPH, and then they typically get in contact with us as infection control. If there's not an infection control department or just part-time, or if infection control is not the individual that's reporting, it would go to the clinician, and then the clinician ultimately feeds that information back to the family of the patient or the patient themselves. One thing to note is not to delay treatment based on case classification. You'd want to continue with your normal clinical course based on the patient's health and improvement. Next slide. So these are, I've included a couple appendices with the health department information. So this is IDPH's telephone, and then all of the other, not all of the other, but can we go back one slide? So quite a few of the County Department of Public Health. It's based on the patient's residence, as I'm sure you all know. So typically when providers or infection control are reporting, we're going through these channels. And this is contact information for the CDC. So IDPH is going to arrange the submission of medical records and patient samples to the CDC. All communication and submissions should go through IDPH to the CDC. The contact information here for the CDC is mostly just here as supplemental information or ancillary information. You would want to try your best to go through IDPH before any other alternate route. And then here's a list of resources and required forms. So there's quite a few. There are things like the clinician job aid that may be helpful to send out to known clinicians in the area that may be dealing with potential pediatric cases of this. There is the CDC AFM landing page. This will give you all your information as proposed by the CDC. The CDC submission form, specimen submission form, the patient summary form, the IDPH AFM landing page, the LHD jurisdictions, the MRI image upload site, the laboratory submission form, and then again, INEDS portal registration. If you don't have access currently to INEDS, I would highly suggest registering and try to get access as promptly as possible. And then that is it. And then I think we'll go ahead and start the QA portion of our presentation.
Great. Thank you, Matt. This is Jana Simon from the Illinois Public Health Institute. We have the chat box open and ready for any of your questions to either Dr. Patel, Matt, or Heather Reed, who's here from the Illinois Department of Public Health. So if folks want to add their questions to the chat box, we can read those and have them answered. And in the meantime, I had put a question in. Should local health departments work to educate providers in their areas about AFM, or what other learning opportunities are for clinicians in their areas?
So as part of this collaborative, one of our goals is to educate and have far outreach, whether it's for clinicians or infection control practitioners or local health departments, to educate a bit more about AFM. I think given that this occurs or is thought to occur biannually, the focus and attention to it would be important. So if the local health departments have the ability and the connections to work with their providers, I think that would be really helpful. There will be a lot of different types of resources regarding educations or even literature that comes out through this collaborative that could be used for that type of education.
Great, thank you. Someone else has asked, will the slide presentation be sent out to attendees after the day? And I wrote back, yes. Currently, the PDF of the slides are in the handout section of the toolbar for the webinar, if you want to grab them from there, and we will also email them out with a recording, a link to the recording when that's ready soon. Does anyone else have any questions for the presenters or for Heather at the health department, the state health department? We'll give folks one more minute to type in, and if we don't see anything, then we will conclude. All right, well, seeing none, I'm going to copy and paste a survey link into the chat box. We'd love for everyone to complete a post webinar survey. Any final words from any of the three of you, our presenters today?
This is Heather from IDPH. I just wanted to tell you that I appreciate you guys doing this. You know, we're buried in COVID, and this is great that you were doing that and had such a good turnout. So thank you.
Yes, thank you, everyone.
Thank you, Jana, Heather, and everyone for joining us on this webinar.
Thank you.
Great, thank you. Have a good day.